Upon Dr. Mukesh Sharma, who is the present Chairman Scientific Committee of Oculoplastics Association of India, a great, I should say, a very great surgeon, a great academician, and also he was the past president of Jaipur Ophthalmological Society, and also he's the organizing secretary of AIOC 2026. So we are very thankful, Dr. Mukesh, for having this wonderful session, and also look forward to your talk.
Thank you, Dr. Kasturi, for the kind words. So today I shall be speaking on MMCR, and I have no financial disclosures to make. We shall be having Dr. Santosh Honawar shortly. He is busy with some administrative work here. He is General Secretary of AIOS, so he will be talking on levator resection. So when we talk about posterior lamellar approach ptosis surgeries, there are various procedures available. Fasanella servate is one, Muller's muscle conjunctival resection, which I will be talking, is the other one, and posterior approach levator procedures are some other procedures. But MMCR stands out, and this is the procedure of choice for posterior lamellar approaches nowadays. Generally, these approaches are preserved for mild to moderate ptosis. In any case of mild to moderate ptosis where we want to contemplate this, we do first phenylephrine test. If it is positive, it means Muller's muscle is functional and MMCR would be successful. Then we take a patient for MMCR. If it is negative, then we'll have to go for other surgeries like Fasanella servate or maybe levator resection. So how to do a phenylephrine test? We all know about it, but still we instill 2 drops of phenylephrine drop, and after 5 minutes we check for MRD1. If there is rise in MRD1 of 1.5 mm or greater, it means Muller's muscle is viable and MMCR will be successful. There are various nomograms which are suggested for MMCR. Dressner has given one which is quite popular. Here what he suggested is that 4 mm resection should be done for 1 mm of ptosis, 6 mm for 1.5 mm, 8 mm for 2 mm, 10 mm for 3 mm, and maybe 11 to 12 mm for more than 3 also. He has suggested that MMCR can be done for more than 3 mm of ptosis. And if phenylephrine test is little less, suppose only 1 mm of phenylephrine test is positive, then additional tarsus resection may be also included. And then Paris has given his own nomogram. What we are following is this: we have done some modification based on our own experience. So we do, these things are almost same, but tarsus resection we are doing in conjunction with this nomogram, and we resect up to 2 mm of tarsus in MMCR, 1 mm for additional 0.5 mm of ptosis. So these are the steps of MMCR. We'll see these steps in video. So this particular patient was, I think, 6-year-old, and its surgery was done under general anesthesia. So lid is everted on a Demars retractor. You can see the tarsus line, lower margin of tarsus, and we are marking 4 mm from this. So we intend to resect 8 mm. If you want to resect 8 mm, because tissue are folded here, so you mark at 4 mm. These marks are deepened by diathermy, and it gives you hemostasis also. Then we are passing 3 stay sutures, silk sutures. You can use any suture thread also. These are just to hold. And then this intervening tissue is pulled up. You have to pull these sutures towards ceiling so that this tissue is being tented up, and you can apply your clamp very easily. So once you have grasped the intervening tissue, you apply your diathermy ahead of this, so that after cutting this tissue, bleeding will be less, and then we pass a running suture. So we are using 5-oproline here, 6-oproline, sorry, and we pass it in a shoelace manner. It has been entered in through the skin. Then we have reached onto the conjunctival surface, and with the help of this clamp, this suture is passed in all this width width of lid. So we have passed it, and this suture has to be around 2 millimeter away from the metal margin so that you don't cut the suture while cutting the tissue. So once you have reached onto the next end, you come out again in the skin. Now you just pull on to this clamp so the tissue are taut, and with metal to metal contact you cut the clamp tissue by the help of this knife, BP handle knife. So once you have resected the tissue, I have included around 1 millimeter of tarsus also, because the ptosis was around 3 millimeter in this particular patient. Then you can unfold the tissue and measure how much you have resected. So this is folded tissue, 4 millimeter. Now just for our own interest, we will unfold it and measure the unfolded tissue. So this will be double the amount of measurement which you have made. So it was 4 millimeter. So this intervening tissue is 8 millimeter. So once you are done with this, you tighten these two ends, place a knot, and after 8 days or so you just cut it here and pull out this suture. So it's a very neat surgery, bleed very less, post-op morbidity, swelling and all, they are very less. Patient recovers very fast, wonderful results actually. So MMCR, I believe it's the first choice for most cases of mild to moderate ptosis, of course with good levator function, and phenylephrine test has to be positive. The other advantage is that it is fairly predictable. It gives you very good cosmetic outcome without any skin scar, without any other significant complication. Learning curve is not significant. There may be some disadvantages. You can have fornicial conjunctival shortening if you are doing it too much, like if you are resecting around 10 millimeter or maybe more than that. But nowadays, instead of resecting more, we resect some amount of tarsus. This shortening may be of some value if you want to contemplate glaucoma surgery later on. And of course, in severe ptosis, you have to have some additional measures. So to conclude, there are various approaches available for posterior lamellar ptosis surgery, but MMCR is simple, predictable, and relatively complication-free surgery. Thank you for your patience hearing.
Thank you, Dr.